Hi, welcome to the podcast. Today, we're incredibly excited to have Dr. Mikel Daniels with us. As a contributor to the AI Journal, the president, CMO, and managing member behind We Treat Feet Podiatry, which is based in Owings Mills, Maryland, Dr. Daniels brings a really unique perspective on the intersection of medicine, practice development, and AI applications in healthcare. He's going to be sharing his invaluable insights on growing a medical practice, using AI from the clinical and operations perspective, the potential pitfalls and legal considerations of integrating AI into the practice, and how to navigate both patient privacy and medical liability in this evolving landscape. Get ready for an interesting conversation with a true pioneer in this space, Dr. Mikel Daniels. Dr. Daniels, hi, thank you. Thanks for taking the time to spend with us this afternoon and sharing your perspective. So first of all, let's start out. Tell everyone what you do, what your practice does, and how you got there.
Well, thank you for inviting me on. I'm excited to be here today. I, as you mentioned, run We Treat Feet Podiatry, and we're a podiatry platform based in 3 states. It's Pennsylvania, Maryland, and now Washington, D.C. I don't know if you want to call D.C. a state or a territory. I never know how to refer it to. We're in 2 states and a territory. We, are a typical podiatry practice in the sense that we treat everything from, very simple toenail issues to very complex limb salvage and amputation prevention. Cases. I started 2002. I finished my residency, and I joined a gentleman in practice who had been sitting in his basement office for 30 years by himself. So 4, I was making more money than he was. So I took a pay cut to become a partner. 2007, I bought him out and started accumulating practices through acquisitions, mergers, and de novo integrations. And as I said, now we're 11 offices across 3 states. We have an ambulatory surgical arm, where we have ambulatory surgical facilities that are specifically for podiatry, a durable medical equipment arm, PCR microbiology lab, billing and consulting arm. So, we handle everything when it comes to foot and ankle. That's what I do. That's how I spend my days.
It sounds like your days are very full. Do you hop around to all the different offices yourself?
Well, that wouldn't be real practical. So today I was in our Washington, D.C. office. I go there on Mondays. It's a kind of a hall, and there was a big accident on the Beltway today. So that was not fun getting home. I'm glad I made the podcast. But no, I spend my time between DC once a week, Owings Mills the rest of the week, and I spend a considerable amount of time in the hospital doing inpatient work, because the portion of my life that is still practice is basically, devoted to wound care and limb salvage. So I only have 3 kinds of patients: those that have wounds, those that had wounds, or those who will have wounds. So I keep pretty busy doing that. I say I do wounds, and unfortunately business is good.
Yeah. Do a large portion of the limb salvage come from diabetics?
Absolutely. Yeah. I mean, again, it's probably 75 or 80% of the patients that we're having who are amputation candidates, whether they need them or we're attempting to prevent them, are diabetic. We do see ones that are related to vascular disease. Very infrequently do we get things like malignancies or those sort of things, but we do get a bunch of weird vascular cases sometimes. Things that most people have never really heard of, that I've been doing this long enough that I've seen. And I've had plenty of cases where I've something I can say from a doorway because I've seen it before. And one of my other colleagues will be like, "What's that? Never heard of that before." And I'll be like, "Aha, spend 25 years doing wounds, and you'll see it all too someday."
So over that 25 years, as diabetes has been on the rise, are you seeing a direct correlation with the issues of that and having to deal with limb salvage because of the rise of diabetes?
So it's interesting. I asked this question the other day about what I thought GLP-1s would do to my business. And, I had to think about it for a second. And GLP-1s, there's a couple of problems with them. The first being is what happens after you lose the weight? You stay on the medicine. Number 2 is it doesn't change behaviors. It just adapts behaviors, because, if you're having trouble losing weight and you go on a GLP-1 and lose a lot of weight, how are you going to keep that weight off? There's always that second part of the treatment that people seem to forget. And, number 3 is Americans in general are getting older, fatter, and sicker. So I really doubt I'm going to go anywhere. We had the same kind of thought, I want to say probably 15 years ago, 20 years ago, when banding and gastric sleeves were all the rage and everybody was getting those and losing all this weight. And what I found over the years is a lot of those patients are back because they have, regained the weight. And it's one of those things where, as I sit here and I think that the end of my career is much closer than the beginning, I don't think I'm really going to have to worry about or work with. Haven't really seen a decline with the GLP-1 stuff going through. Who knows if the new Wegovy pill will move the needle at all? But at the end of the day, unfortunately, I'm not really worried about it because you still can't fix human nature. I tease patients sometimes about, I call it playing ostrich and sticking your head in the sand because you're ignoring your problem.
So, obviously, sadly, business will be good because of that, sadly for the American population. But other, what would you say you see as your biggest struggle right now then with your business, either from a operations perspective or patient acquisition, any of
Well, I
that?
mean, the key problem that we have, and I think this is what you're seeing in all of medicine right now, is the fact that our revenue generation is not keeping up with the inflation that goes on throughout not only healthcare, but the economy in general. Last year, for example, we got a 2.8% Medicare reduction in fees, and that's on top of, and then there's a 2% sequestration on top of that. So this year they tried to pretend like they were giving us something when they claimed to give us a 2.5% bump in Medicare, but they did get rid of the sequestration. And that 2.5 isn't really 2.5; it's actually 2.1 because of the way they calculate the increase with RVUs and how they split those up. Probably a conversation for a different day. So we're really not even getting back to where we were in 2024, and yet my electric bill has gone up, my rent has gone up 3%. Benefits for my employees have gone up. Electricity has gone up. Everything's going up except for my reimbursement. So um, the old way of thinking in podiatry, at least, used to be, well, you just kind of move more patients through the practice, and that's just no longer a practical alternative because, especially in my world where my patients are relatively complex and I can't be in and out of a room in 3 minutes, which is what you really need to do almost today to make it. So we've made changes to our practice model to try to adjust for that, primarily introducing new service lines for our patients. And it's not new things that we're doing for our patients per se. It's things that we were sending our patients out for, like compression garments, for example, or as I mentioned, labs. We now do those in-house so we can capture the revenue. We're not ordering anything new. We're not doing anything we weren't doing before. But I always say I never saw one single patient that Quest or LabCorp sent to me. So why did I keep sending my specimens to them? So now we do
Indeed.
those in-house.
Well, that makes sense, trying to keep it all there underneath your roof. Are you seeing more patients just not even have insurance and coming in self-pay?
So we're pretty fortunate here in Maryland. Without getting political, we have a very, very good exchange for health insurance and a good reinsurance program. So health insurance here tends to be more available to people than it is in some other places in the country. So the number of uninsured patients we have is, I mean, almost nothing. And it's much less than it was before the Affordable Care Act came in. Just because they have insurance doesn't necessarily mean it's good insurance, but they do have insurance. So, for catastrophic things like hospitalizations and amputations, basically everybody's covered. And the state has catastrophic plans. So people come into the hospital without insurance. Uh, a lot of times will end up on one of the state-based plans. So we don't really see that quite as much as some of our colleagues in other parts of the country. But I have been reading quite a bit about how the uninsured rate is starting to creep up and the expectation that it was going to creep up after the December open enrollment period, but haven't really been seeing a lot about that lately. So I'm not really sure what the verdict is. It might just be too soon.
Hmm.
But as an answer, no, we're generally seeing that our patients are covered. But of course, deductibles and copays are going up every year too.
Making it more challenging for lots of families out there. So you talked a little bit about some of the struggles and how you've adapted to overcome those. What are some things that you're most excited about in the future for your practice in particular?
I've been answering that question by saying retirement. I'm very excited about that someday. We are. I always try to be on the cutting edge of practice management and advancement, and trying to figure out how we can get more from less. Which I say everything in medicine these days needs to be better, cheaper, and faster. And if you're not better, cheaper, or faster, you better just go away because you're not going to make it. So, the first thing that we did, and we did this going on almost 2 years ago, is we were early adapters for ambient AI technology for chart notes. The reason why that's consequential is that, aside from the fact that it allowed us to pay more attention to patients, because again, I've written an article that's going to be published in the next couple of months about how the doctor-patient relationship is dead, gone, history, and now it's the doctor-EHR patient relationship. because there's a third party in that relationship all the time. And sometimes that third party demands far too much attention. But we're able to now sit back and let AI observe the visit and then create a structured chart note for that visit based on what was said and interacted between myself and the patient. The reason that is valuable to us is what we noticed very early on, and it's kind of progressing down, is there were lots of things that we did during patient visits that were just part of our kind of rote consciousness of saying things that we never really documented. And as we've started to document them, and as it's been in the note, and we look through the rules for medical decision making in office visits, we were very much undercoding our visits. So it's allowed us to, have CPT creep basically, just because instead of, writing it afterwards, it's the note is being taken and the visit is being monitored. So what we're actually doing is realistically being placed into the note. That has made a difference in our bottom line, which is nice. But then adaption for all the physicians in the practice can be difficult. Younger doctors seem to adapt it pretty quickly. Older doctors are old dogs, new tricks kind of thing. And sometimes they don't see the benefit. Whereas in my mind, and I guess maybe I am one of those old doctors, but in my mind, this is fairly simplistic. Is you're getting a better product. The note, it has more information in it for both, you, for the patient, for a third party to read. And as a result, you're actually getting paid at a more appropriate level comparative to the work that you're doing. 2021, when they changed the requirements for E&M coding and we left the 95 and 97 requirements behind and went to the new medical decision-making model, a lot of doctors never really adapted. Old school thinking still persists through the profession. So I think ambient listening technology has really been a huge driver, and I think you're going to see more and more and more of that going forward.
What are some other ways that you utilize AI in your practice currently?
So we utilize AI a lot for our marketing activities, primarily for things like idea generation or proofreading, or sometimes, to generate images, as opposed to, either having to, find an image and pay for, copyright, or, have less than desirable images, although some of the AI images can be pretty funny. You got to be a little careful with those.
The extra
Um,
limbs and things like that.
yeah, there are two doctors standing around a foot, and at the other end is another foot. So we've seen those. But we also use it for data analytics, primarily for combining the financials for different parts of our company. As I mentioned, we have different service lines. So different service lines are actually, in some instances, different companies altogether combined into the practice and into the platform. So, to get combined reporting, it's now much, much easier because we don't have to worry about adding lines together for multiple sheets. AI will do that for us. And it will also be able to tease out the important information that we're really looking for. It's the same thing with billing patterns. We can compare each other very, very simply using AI to determine, if one doctor is, far out of the bell curve compared to others and why that is. It helps with our education for doctors and patients, and everything that our doctors do that's better is better for patients. And that's the end of the day what we're set for. So we have those, and we're really still kind of exploring other things that we can try doing with AI. Things like message retrieval and discussion. We've failed miserably with AI phones. If you want to talk about that, that's a huge catastrophic failure on our part that we've seen. But we are thinking that patients are becoming less and less intimidated by AI.
Mhm.
And, for me, it's kind of fun to take my elderly patients who AI is a news story. They understand it all and tell them, here's the practical use. It is going to take notes while we're talking here and produce your chart note. So you are now using AI, whether you know it or not. And they tend to think that's a pretty neat thing. One of those little, I don't know if you want to call it a marketing tip, but I try to tell patients what we do and how we do it to try to as a differentiator for us.
I do think that's where AI really shines, is where it can analyze data, streamline operational perspectives to allow more time for that personal interaction. And I think I hear so many people say that they feel like oftentimes when they go to the doctors that they're just being rushed through. And I do understand from your perspective, right, that you're allowed so much time really to see a patient in order to be efficient and consider the cost. So if you can eke a couple extra minutes out of that, I think patients really appreciate that and they feel the difference with that. So let's talk a little bit, yeah, just touch on a little bit about your AI phone failures. Let's talk about your failures for a second. Why was it such a failure?
So people generally do not like speaking to AI, even
Mhm.
if they don't necessarily know it's AI. Most people are swift enough to figure it out pretty quickly. Our biggest issue was that there were two issues. The biggest issue was is that people are generally, to put it nicely, very cruel to the AI and say things to AI that they, I would hope, would not say to any other person to their face,
Mhm.
without the realization that everything you say to AI is likely being transcribed. So we would see these transcripts, and there's something to say about a 90-year-old gentleman cursing AI out like a drunken sailor. And it happens on more than one occasion. So that was part of the problem. The
Mhm.
other issue with it is, and this focuses around a practice management or a practice operational issue, is how do you use AI to properly fill your book? And I mean that by thinking of it this way. So I've been there the longest. I'm the first name on the door. So lots of the phone calls that come in are for appointments with me. Well, the reason I have all these other doctors is because I can't see all of those patients. There's just not enough hours in the day. So, the ability to understand that concept and to try to place a patients with other doctors and to understand the ones that are not going to have that, or to understand the ones that are perfectly fine with it, it's a difficulty there. And then the integration with a scheduling software also possesses a problem, because you can tell it who's where and what, but there are certain intangibles that go with a human-human interaction that AI can't. So for example, my staff knows that if I have somebody and it takes them 20 minutes to explain why they need an appointment, that putting them into a single slot is probably not going to help the schedule that day. So they would know to double that up. Where AI, we would have to have a very, very finite line. And for all we know, somebody could spend 15 minutes coughing through that visit. And next thing you know, you have a 2-second problem in a double slot. And then you got a doctor not doing anything. So those things were problematic. The last thing is I have a personal disdain for the ability to book online appointments. And I say that primarily because people will call up and they will give us basically all of their information: their name, their date of birth, their address, their insurance information, their driver's license number, their social, you name it. Any piece of personal data that we basically ask for, we will get on a phone call and then not show up for the appointment. And that blows my mind because, I mean, again, I am very careful about whom I give my personal data out to. You kind of need to be in this day and age. But who spends 15 minutes providing all that information and then doesn't show for an appointment? And
Mhm.
statistically, no-show rates for medicine are about 10%, which is where we are. It drives me absolutely insane because we do everything we can to get patients in as quickly as possible, to move people around. We have physicians willing to stay later to see people if there are emergencies. And then for them to go all through all that information, for us to spend 10, 15, 20 minutes of staff time making that call, and then for them not to show up, it boggles my mind. I
Mhm.
can't figure out what happens there, but it happens all the time. And I think if you can do it without a person-person interaction, whether it be through AI or through a website where you click a spot, not showing up is that much easier because there was less invested in making that appointment.
Mhm.
So maybe it's old thinking in my part, but I think that human-human interaction cuts down on the no-shows, and that's kind of what we're working at now. Lastly, is that sometimes the integrations get kind of messed up, and you end up with weird things. Like you end up with 6 patients in 1 hour and another one 3 hours later, and you don't understand why they're all bunched together like that because of the way it's supposed to be filled. Those little interactions, I think, are where AI still has some growth rate. Lastly, AI had trouble answering some questions. Like AI is supposed to be able to give you directions. I mean, it does have maps in its brain, right? And it
Mhm.
couldn't give people directions. It would tell people to go, people would call and it would say, oh, go find it on our website. Well, if they're calling, they clearly don't want to find it on our website. Or they sometimes would give people wrong directions, which blew my mind because there are hallucinations that occur. We see it in our own AI documentation. We get hallucinations sometimes, which slows us down. It'd be nice to be able to just cut and paste it right into a note, or press a button and paste it right into a note, but you can't do that because
Mhm.
sometimes it comes up with some funny things. I've been keeping a list, and one of the days I'm going to start a Twitter handle about what that my AI says,
Yeah.
because some of them I can't even figure out what it's talking about. Those are the
Mhm.
best. Or when I can figure it out and it's just so wrong, it's humorous. And I have a list. One of these days, it's one of my many projects that I'm going to do probably when I retire and have free time to do this stuff.
Like an AI bloopers kind of situation.
Exactly.
Everyone loves the bloopers. No matter what the scenario is, everyone loves the bloopers. Yeah.
People have been doing that with Dragon for years. I'm going to do it with AI.
Speaking of info, and particularly And anytime there's a doctor-patient situation, there is an extra level that other industries don't have to deal with, which was the whole HIPAA issue. So, how does that complicate your ability to use AI?
So when we first started doing this, so it was 2023 when we first started looking at AI phone solutions. And the first company we were talking to had absolutely no idea about HIPAA, didn't understand what it was, didn't understand the concept, didn't understand the concept of a business associates agreement, nothing. And actually, we got pretty far down the road before we said, okay, well, if you want patient data, now we need a BAA. And they said, what's that? Yeah, because again, first it was initial, they were a relatively new company and they were just designing this thing and we were talking to them about our needs. So that was it. So the second company that we tried, has a HIPAA compliant product, which is great because you need it. The problem is, and this is where there's a little bit of lack of clarity with HIPAA. If you call my office and you want an appointment with Dr. Smith and you talk all about your medical problem to the AI, and then I'm reviewing that for some reason, I don't have the right to that information, even though it's my own practice. That's between you and Dr. Smith. So you're exposing medical information sometimes to places where they won't. And there's workarounds and there's exceptions. And quite frankly, at the end of the day, it's not probably a HIPAA violation. But that's one of those, well, it gets a little bit too close to the line for comfort for me, especially given the penalties. And I want to be able to see that HIPAA line a mile away and stay far away. It's kind of like a puddle with an electric wire in it. I don't want to go anywhere near that either. So we don't even want to get close to being a problem. So you create some problems along those lines with that. And then the third thing is there is a lack of understanding about HIPAA in general. The lawyers are obviously very good at it. There are corporate medicine people who, work with it constantly who do that. But smaller independent companies just do not. They get a opinion from their legal team and then they try to interpret that themselves and go about. And you get too close to the line. So patient information is paramount to what we do and protecting patient information. And people are like, oh, you do feet. What's so problem about that? Well, you never know. It's not a matter of what's so bad. It's a matter of what does somebody want revealed versus not. We do the thing where if I see, friends or relatives as patients in the office, I don't tell anybody. I don't come home and say, oh, guess who I saw today? Because you just never know. Unless that individual says, say hello to, my wife, my in-law, whatever.
Mhm.
I don't ever talk about seeing them. I don't talk about my patients. I don't talk about my work at home, which I think sometimes makes my wife feel I'm closed off. But I'm preventing any misunderstandings or anything that could possibly get me close to that line. So I think I take HIPAA, incredibly seriously, as I think everybody else should, but perhaps that's not always the case.
You guys were kind of some of the early adapters back in 1920 in 2023. Which just goes to show how really new most of this is and how there's lots of practices that aren't utilizing AI in any way, shape, or form. So because it's so new, some of the rules are still being written. Do you see in the near future where those guidelines will be a little more specific concerning HIPAA and AI specifically? Or is
Well,
that evolving?
CMS put out, I don't know if you want to call it an opinion piece or a paper in either July or August of last year about using AI for coding and billing purposes. Because in theory, AI should be able to, determine exactly what's in your note, exactly what level that meets, and provide you with accurate coding information. And I haven't really started seeing any of this yet, but I imagine there's going to be disputes between the human coders that are being employed to review notes and the AI, which is objectively placing codes on there because we're still responsible for it. Our own AI system does have suggested CPT level codes, but sometimes it gets it wrong too. And I will be amazed how it will list the medical decision making, the three components of the medical decision making, and then say it's, moderates, lows, whatever they are, and then pick the wrong CPT code compared to what it just said. And you got to watch it. You got to watch it carefully because it makes a big difference. There's significant, revenue consequences if it's wrong, either way, a high or low. So
Mhm.
those issues you kind of are abounding. But I do think that you're getting to the point now where you're starting to see large adoption of the technology. And with that, I'm sorry, adoption of the technology. And with that adoption, the rules will kind of start falling into place, because unfortunately usually the rules follow the technology, not lead the technology. And I think now you're starting to kind of see that catching up. And that paper on the CMS website was a big one, because I took that and wrote guidelines for our practice as the chief medical officer. This is what we do with AI, and these are the practice guidelines you need to follow, and you need to indicate that you read them and that you're going to follow them. Because again, I didn't know is not an excuse. You can't use that as a defense. You got to know. Whether you want to know or not, you got to know.
Is there still one component of your practice that you would love to effectively be able to utilize AI so that your business could run more efficiently?
So I've been known at times to tease my employees when they're doing something, when something goes wrong, that I'm going to replace them with AI robots. That's kind of a big thing that goes around. I say it in jest, but I do think that there are more efficient ways to move patients in and out of the office than the receptionist sitting at the front desk. That is still the majority of practices. I myself went to Quest to give blood a couple of weeks ago, and I met by a kiosk that took my driver's license and my insurance card and scanned my order. And next thing I know, I'm being called back, and their vampires are taking my blood, and everything went great. I barely had to interact with anybody, except it wanted my credit card for my projected copay. Okay, fine, I did. And then I got an email a couple of days ago. Oh, you're refunding your copay because your insurance paid for it. It's like, okay, well, you're kind of Quest. You might want to know that next time. I mean, I don't really care because it was $21 or something. It was not a grand amount of money. But, for somebody who doesn't have insurance, or somebody whose insurance, everything goes to deductible, it could be significant dollars depending on the tests. So, those sort of things I think are going to work out, because if you think about the way health insurance is in this country, the people who designed the systems were mad geniuses. Because name one other thing that'll happen where you and I will have an interaction where I will provide you a service, you will accept that service, and a third party pays for it. And if your third party doesn't pay for it, you're mad at me, not them. Think about it.
Yeah.
Pretty brilliant from a business model perspective. From
Mhm.
a physician's practice, it's terrible. But
Mhm.
the business side of me goes, wow, I wish I could figure out ways to do that and other things. That would be great. So those sort of things, really kind of work through. So this kind of transparency in billing and transparency in, what's owed, that will improve as well. And that also can be kiosk driven in the front office area. Until the Elon Musk robots can wipe down and clean treatment rooms, and put out paper things, and clean instruments, we're still going to need humans for that for a long time. And as I said, I seriously doubt I'm going to have any Elon Musk robots in my office during the course of the rest of my career.
Well, we've talked definitely a lot about how AI is utilized in sort of the operations perspective, but how about more in the clinical aspect? And we certainly have robotics for different surgical procedures already at this point. Do you utilize AI in a clinical way? And do you see anything in the near horizon that will be advancing towards that?
So we do use AI to take things that we do in the office, like for example, a gait analysis where we'll get a bunch of figures and let AI create the actual report that explains that. Whereas before we would scribble some notes into the chart, or into the note that day to indicate it, and now you can get a whole report. And that's basically for patients only. I don't really need that information, but patients now, everybody has access to their medical records all the time. So it's nice for them to be able to look at it and see it and have it explained out in a way where I don't have to sit and explain it, because that's not a productive use of my time for those sort of things. Where I really see it and where I really love to do it is getting all of my all-in-one systems that don't talk to each other to talk to each other, because none of them are actually all in one. My X-ray system to talk to my electronic medical record system, to talk to my answering system, to talk to my billing system, to talk to my scheduling system. I would love all these things to sit around a bonfire and sing Kumbaya together. And I do think AI can do that eventually, but it's not quite there yet. I mean, with Make and NA8, those sort of things. But then you start running into HIPAA issues. So you got to be careful with those as well. So one of these days, that I might see at the end of my career. I think I'm on a collision course with that.
Mhm.
I'm certainly trying to find things that do. I do get very often messages on LinkedIn from integration companies that say they want to solve my biggest challenge, and then they want to ask me what it is. Well, if I have to tell you what it is, how are you going to solve it? That's not a good productive use of my time. It's to tell you what work you can then bill me for. I
Mhm.
cannot tell you and not get a bill. That would be very good with me, because everything's expensive. So I think as these kind of all-in-one products, one, meet the HIPAA standards and all of those crazy things, but number two, can start actually doing them for themselves. AI teaching AI, or AI sitting back and watching your interaction with a program and being able to then develop that, automate that interaction without any coding need, which I know some of these things are starting to become available. I think those will be game changers for us, and that's where you're going to start, squeaking out time. You have to understand, people, when they come into my office and, we sit there and we have a pleasant conversation and I help them with their problem. They're like, oh, thank you. Wow. You really must love what you're doing. I go, no, I hate this. And they go, what? But you seem to like it so much. I'm like, yeah, I like this part of it. It's the part you don't see that I can't stand. It's the reading through a dictation to make sure that AI got it correct, or, that we documented everything, or that we didn't forget anything, so I don't have to send you a follow-up message because I was like, oh, hey, by the way, I forgot to tell you this. But
Hmm.
those are the parts that are terrible because, it's sitting in a dark room in front of a screen. And at the end of the day, even though, the majority of people in the world seem to do that now, it's still not the best way to spend your time. You should try to be outdoors, except when it's 21 degrees here in Baltimore. And I don't want to be outside. It's too cold.
Yeah, I get that. Although if the sun is shining, I do sort of push myself out this time of year because if not, it could be 2 months before I
Yeah. I go to
emerge
work.
from the cave.
I go to work. It's dark. I come home. It's dark. There's no sun in February.
It's a challenge. Just a couple more questions. If you could go back to the start of your practice, is there something you would say to yourself at that time that you think would either have shifted your mindset or the path that you took?
I think I would have told myself to do a better job checking my ego at the door. And I don't mean that in a way I communicated with patients, because I've always done whatever it takes to get patients taken care of. But I figured out as I've matured in my practice that the surgical portion of my practice is not the part that gives me any joy. In fact, it's the part that gives me the most amount of stress and aggravation. So I probably would have tried to tell my younger self that, maybe you should take a look and start focusing a little bit further away. I also would have told my younger self to go get an education before you actually started running the business. In 2007, when all of a sudden it was me and nobody else, and I had to start making all these business decisions, I didn't know what any of them were. I didn't understand the concept of financials. I didn't understand integrations. I didn't understand mergers and acquisitions. All of the stuff that I have gone to the school of hard knocks with, really, really would have been beneficial. And I jokingly say, I think I've made every expensive mistake you can possibly make in podiatry. So please learn from me, so you don't do it. But at the end of the day, I doubt I could have taught younger me, because, we all look back at our younger selves and say, who was that person?
Mhm.
Oof, not somebody I don't know how I ever got here. How did I survive? I look back, how did I ever survive high school and college? We did some stupid stuff, but
Mhm.
at the end of the day, I would say, I wish I had had more of a business education about running the corporation before I actually started running the corporation.
Well, it sounds like you actually have a lot to offer. Have you actually thought about mentoring younger physicians that are looking to build out a practice?
We do, except nobody's looking to build out a practice anymore. Somewhere in the last 15 plus years, medicine basically went from being a career to being a job. And, you have people, doctors coming out of their residency programs, and none of them are looking to go start a practice somewhere. They're looking for jobs, and they want job security, and they want guaranteed salaries, and they, want things handed to them. And I think every generation thinks the next generation is, you pick your adjective of choice. None of them are flattering, and, how are we ever going to survive, and who's going to take care of us when we're old? Those sort of questionings there. But at the end of the day, when I was finishing residency, it was you went out and you joined a practice and you hoped to buy in and become a partner, or you worked there for a while and then went and bought your own practice somewhere else. That was all. There was an entrepreneurial spirit to it, which is now basically almost non existent. So there really is nobody to help build out practices. The amount of independent practices is diminishing rapidly. We're one of the larger podiatry practices in the country that's not private equity owned. Most of them are nowadays. So, and everybody says, well, why aren't you? And I say, well, they come with a big enough check. I'm there. But, part of it is also, a lot of these practices don't get to be this size. And it's really hard to try to figure out how to integrate and how to really identify costs, because things get split up a little bit differently. If you're one or two doctors in one or two offices, everything's pretty easy. When you're 10 or 12 doctors in 11 offices in three different states with different tax structures and different scope of practice requirements and different licensing issues, it gets a little bit more complex. And, that's kind of the problem that we have. So I think at the end of the day, um, it- there's not a lot to mentor. The mentoring really comes in helping business people understand medicine and being able to do basically the translation. Because when I started, most of the hospitals were run by doctors. Today, there's one doctor in the C suite, the chief medical officer, and hardly anybody else ever is in any medical organization. And when it comes to what doctors say and speak about and what MBAs say and speak about, it is vastly different, and they could think they're arguing about the same thing and be having an argument about two different things and not understand the other one. When you first see it, it's kind of eye-opening. When after you've seen it a few times, it starts to become a little comical. Because, imagine if you and your neighbor are sitting arguing over the fence because they think the fence is too tall and you think the fence is purple, and who cares? And you're arguing because they want the fence shorter and you want the fence not purple, and neither one is hearing each other. Welcome to medicine.
Yeah, well, you've certainly done a great job of navigating ever evolving and changing landscape. And just one last question I always like to ask my guests. If you could have been born with one God-given talent that you do not currently possess, what would that be, do you think?
I would have liked to have been a better singer.
Me too.
The only hope I have for a career in music is with either somebody like Eddie Money or Eddie Grant, who sings in one note. Eddie Grant was able to make one big hit with a song that's 3.5 minutes of going, "Oh no," Electric Avenue, and they can't sing. I mean, they're good musicians, excuse me. But yeah, I couldn't carry a tune in a paper bag. So I would like to have been able to sing. And aside from that, I would like to have been able to have the gift of being able to sleep. I don't always sleep very well because I'm always doing something and there's always a million thoughts in my head. So I go to work at like 4 in the morning, not because I have to, but because I'm awake and I got lots to do. So I would like to be able to sleep. I'd like the gift of sleep.
Well, maybe in retirement you'll get a little bit more of that, but I have a sneaking suspicion you're just kind of wired that way. So that might be a challenge for you. I'm going to put all of your information in our show notes, but please just tell all of the listeners the best and easiest way to find you.
You can find us at WeTreatFeetPodiatry.com, all one word.
Amazing. Thank you so much. I really appreciate all of your insight. I think our listeners are going to get a lot of value out of some of the complexities of navigating this new space, this intersection of AI, and some of the benefits and some of the pitfalls of where we currently are. So I appreciate your insight as a real pioneer of merging these components together and your conversation. So thank you very much.
Thank you again for having me. It was fun.